Good evening to you all. It's almost good night time. I think without much of an introduction, we'll straight away go to the topic proper. It's cardiovascular risk management challenges and solutions. Many of the information, many of you are quite familiar, but it's good to revise once in a while so our teeth get sharpened. And this talk is like this slide. You may think it's cigarette smoke or it is Ganapati. It's up to you what you are looking at and what you take back. It's going to be about 25 or maybe maximum of 30 minutes. We'll talk of traditional risk factors, the new risk factors emerging for cardiovascular disease, the enormity of the burden and the challenges, then maybe the effect benefits of managing the risk factors. What is the polypill concept? Polycab, a tool to control the severe risk factor, does it do the justice to that? And I feel it's a social pill rather than just a polypill. And if there are any future projections. This is one of my favorite slides, actually quite an old one, taken from a book. Actually, if you see the on the x-axis there is affluence, urbanization and education, and the y is hypertension, lipids and diabetes and cardiovascular diseases. So India urban, we are here somewhere, so we are on the upswing, and in the next 15 to 20 years probably we are going to hit the summit. We are all aware of this burden though, but what's important is the Europe, North America, Australia and New Zealand. All the developing countries are on the downward swing because probably they held such meetings 20 years ago or more. There is awareness about cholesterol. We know that above the age of 50, but in India the age is about 30. Anyone above the age of 30 can get a myocardial infarction. It is preponderantly seen in men, but it is strikingly rising in women. Hereditary is a very funny issue, like someone's father had a myocardial infarction at the age of 45, but he could be a chronic smoker, and it still doesn't constitute a family history. I would say that at least 2 members suffering from a cardiovascular ailment before the age of 55 would be a true family history, because otherwise there are so many other factors involved in this history taking. We are all aware of the diabetes, smoking and other things. Probably I would not spend too much time on this slide because you are quite too aware of all this. From this on, we go on to the non-traditional or the newer risk factors, starting from the high sensitivity CRP, then periodontitis, pollution, vitamin B12, D, LP small a, or depression, sleep apnea, heart rate as a risk factor, and maybe erectile dysfunction as a not a risk factor, maybe a precursor or a marker of coronary artery disease. If you look at the CRP levels, HSCRP levels, if they are very high, then you have a proportion of CHD is going to be very high. And if you have very low HSCRP levels, it is low evidence of cardiovascular disease. So whether it is a marker and whether it just by lowering CRP we achieve this or not is question. But in the large trial, that is the Jupiter trial, it was shown that by using significant doses of rosuvastatin, when you bring down the HSCRP, the incidence also comes down. So, and the p-value is also very significant. So there is a case, but it's not reproduced so very well in all parts of the world. So there still marks a question mark. And I don't think in this audience, not many of you ask for HSCRP in every individual. We are still groping and waiting probably for more data related to this. Periodontitis, this is a farmer coming from a village near Jalgaon, 36-year-old, lean and thin, working in the farms, no addictions, no diabetes, but had triple vessel coronary disease for which he had to be operated on. And he had this horrendous periodontitis. And it's not this, even in the American journals it is said that patients with periodontitis should be cautioned about CAD, and it could be recognized as independent risk factors for coronary artery disease. Mind you, in India, it is not so rare to find this. You can find it quite easily if you are looking for periodontitis. Pollution, we think probably wait for some evidence, but there are already some papers appearing. IAMICON 2007 says that pollution after this study, that each increase in this level of exposure to associated was 24% increase in the CV risk given and a 76% increase in the risk of CV death. Yet again, not corroborated, not fully developed or not fully studied in all parts of the world, so we just wait on this for some time. Vitamin B12 deficiencies causing hyperpigmented pigments. We have traditional lot of people who are purely vegetarians and stop drinking milk at the age of 15 or 16, and for the next many years they remain without any animal-derived product. Very low B12 levels leading to thrombotic states, myocardial infarctions, peripulmonary embolisms, pulmonary primary thrombosis or deep vein thrombosis, sagittal vein thrombosis. We all have experienced these patients in our day-to-day practice. Vitamin D, I won't dwell on it too much because the data is not so clear. Maybe it's more clear related to diabetes. Angina frequency and depression, you can see that angina frequency, when it is daily, the depression levels are also quite high. Sleep apnea syndrome, obviously one of the things which we don't think of, but it's a person like this walks in, probably you have to think of sleep apnea syndrome. Heart rate and mortality in healthy men, it is also seen in patients with coronary artery disease. The higher is the heart rate. This is a follow-up study of 23 years. It is very difficult to derive general impressions from such a study. But yes, higher the heart rate, probably higher is going to be the cardiovascular risk. Erectile dysfunction, it is well known that it can precede almost 6 months prior to a myocardial infarction. A big risk factor which is quite new is adherence or non-adherence for that matter. If you can see that relative risk of a CV event, if somebody is very adherent, that means taking the medicines 80% of the time at least, there is a 50% lower risk of a CV event. Making a new major risk factor is non-adherent to medicines. So as we know, diabetes, hypertension, smoking, we also be aware that if somebody requires these medicines and not taking them, probably also is exposing himself to a major risk factor of non-adherence. Hypertension doesn't come alone, it is a tip of an iceberg because beneath there is a big balloon which is blowing. And in addition to all this, there is non-adherence or new risk factors, and all these are exponential. That means every time a risk factor gets added, the risk increases by the power of 2. There is a striking change in epidemiology. In 1970, the blue communicable disease was 39%, and the non-communicable like cardiovascular disease was 36%. 2008, this has gone up to 63% non-communicable disease, and it is projected by 2030 we'll have a whopping 76% non-communicable, that is cardiovascular and related lifestyle diseases. Causes of death in India, if we see that cardiovascular disease are topping even today. Some years ago, maybe a decade ago, the infections were still dominant, but we are now looking at the CV deaths, which are major cause of death in India as well. This is typically a Nigerian or Ethiopian athlete, marathon runner at the end of the 42-kilometer run. This is how he feels, tired but ecstatic. And this is the Indian counterpart who dips into the Maili Ganga and feels great about it. And their waistlines show the difference between the two. And this, I call it not a metabolic syndrome, but a metabolic sin, because it is a phenotype which can be prevented. And if one gets one, probably it can be altered. And this is what we have to know ourselves and percolate it down to our patients and other families that we are treating. The cardiometabolic syndrome, the situation in India, you can see that between age group of 40 and 60, the abdominal obesity bar is the tallest, indicating cardiometabolic syndrome. The Interheart study, which was a brilliantly done study amongst a lot of Indian patients and appeared in Lancet, it still showed us that despite all the talk about the unusual and the new risk factors, we still have to do well about risk factor management of the traditional risk factors like the diabetes, like the exercise and smoking. If we manage the traditional risk factors well, we are going to manage the cardiovascular risk much better. So our onus is to know about the new risk factors, but yet do very well about the known and traditional risk factors. Lifestyle modification program should have probably a personalized diet and exercise program. Relaxation techniques, whether you are stressed or not, probably are becoming more important these days. All these programs must have a group therapy because that adds to a lot of motivation and continuation with the lifestyle programs. Implementation of above programs is important by way of good motivation. Then comes the pharmacological management and execution of the pharmacological treatment, periodic checks, and managing preventive parameters. What are the parameters that we are looking at? In healthy, where we want to do primary prevention, the BMI should be this: blood pressures, fasting sugars, the HbA1cs, total cholesterols, and the HDL cholesterol, vitamin B12, vitamin D, and HSCRP. If we manage it this way, probably you are reasonably close to prevent a good level of prevention. And somebody who has a vascular illness, including some years of type 2 diabetes, then the values are more stricter, the BMI, the blood pressures, the cholesterol levels, the B12, D3. So all these parameters, if we manage well for a normal individual for primary prevention and for a person who has a cardiovascular disease for secondary prevention, then we are probably doing justice to this individual. Beyond this, what happens is probably beyond our controls. In Pune Hospital, we run this program of lifestyle modification for the last almost 18 years. It is based on all these principles, including yoga and meditation techniques. And what lifestyle change can do, a person who is 38, smoker, non-exercising, a typical IT professional of Pune, versus the Padma Vibhushan B.K. Iyengar, who spread yoga all over the world. Unfortunately, no more now. When the slide was probably made, he was 88 years old, and we looked at the CIMT, the carotid intima media thickening, and this gives you the vascular age of that person. So this person has a CIMT of 0.84, and 88 years old, and Iyengar has a 0.58. So their vascular ages are actually reversed. So you can see that so much difference can be made by just a good lifestyle. I don't know how many of us can become a B.K. Iyengar, but at least we can be somewhere in between where our vascular ages should match, or CIMT should match our ages. So that much lifestyle change as a doctor, at least we should do ourselves and impart it on to people surrounding us. So in risk factor management, I think correct diet and exercise, some techniques of relaxation, group motivational therapy, scientific cost and compliance friendly polytherapy, this will finally lead to a risk factor management because the burden is huge, and unless we follow these techniques very well, our effectivity in management of these risk factors may not be adequate. So based on this new drug therapies now, aspirin can have some effect on the, then ask the aspirin trials, the ramipril trial, another simvastatin trial. If we see how much reduction in events take place, a polypill combining all this can reduce hypothetically the event rate to less than 20, that is 80% prevention of events. And this was floated by N.J. Wald. And just before that, a year before, our own Salim Yusuf had put it into editorial of Lancet. It is possible to reduce by using correct drugs like aspirin, beta blockers, some kind of statin, ACE inhibitor, and the combined effect would be very good, was postulated by these two gentlemen. If you look at survival after nest elevation MI, and if you take all 4 drugs, 3 drugs, 2 drugs, 1 drug, and no drug, you can see that those with 4 drugs like ACE inhibitors, aspirin, statins probably do the best. And the problem is, in this pure study, it was shown that how many people really take the drugs. In urban drugs, if you take all 4, drugs are taken by hardly very few people. Antiplatelets, beta blockers, you can see the beta blockers are the lowest, probably statins, the bar is quite low. So very few people end up taking all these 4 drugs, and that's why there has to be a strategy by which all these 4 drugs can get delivered in a compliant pack. And this was achieved by the polypill to polycap, a concept that was realized by using 1 flask. You can fill up 2 glasses. That means bring in some compliance ahead, and that came through polycap, the tips to secure life. And this polycap concept it started way back in 2003 through the literature review and new concept production, till it was published in 2009 in the Lancet. Then the TIPS 2 study came. This was for secondary prevention using double dose of the polypill. And now the 2013 TIPS 3 trial of more than 1,000 patients already onboarded. It's 1 capsule with multiple drugs, and each has it's a gelatin capsule which contains 12.5 milligrams of hydrochlorothiazide, 50 milligrams of atenolol, ramipril 5 milligrams, 20 milligrams of simvastatin, and 5 milligrams of ramipril, and 100 milligrams of aspirin. All these components are known to have their own preventive effects, whether it is primary and secondary. The challenge was to put them together into 1 capsule, because when they are brought together as powders, they may not remain pharmacologically stable. And the challenge was there to put all the powders together, make it a smallish pill which can be swallowed, and yet retain the effectivity and pharmacodynamics of each individual components. That was well achieved and maintained the bioavailability very well. There were no pharmacological interactions. 92% patients completed the trial, and polycap preserved the individual pharmacokinetic profile, which was proved. This appeared in the Lancet, showing that the polycap, 1 BP lowering drug and 5 drugs together, had a much better effect on the systolic and diastolic. It stands to logic, the more number of drugs, the blood pressure is going to be well controlled. We know that recent 2013 ACC/AHA guidelines indicate that majority of the diabetes without atherosclerotic cardiovascular disease, or anyone in whom we calculate the risk as more than 7.5 for the next 5 years, would require a moderate intensity statin, something which would lower the LDL levels by 30%, and that is achieved by 20 milligrams of simvastatin or atorvastatin, or 10 milligrams of rosuvastatin. It's also known that aspirin is very good for secondary prevention and to some extent in primary prevention. In 2012, European Society Cardiological Guidelines indicate that individuals without cardiovascular disease demonstrated that the polycap formulation could be conveniently reducing the multiple risk factors. So this was projected for a primary prevention in this. And in 2013, the ESC guidelines indicate a fixed dose combination of several antihypertensive drugs with a statin and a low dose aspirin, with the rationale of hypertensive patients often present with dyslipidemia and not infrequently have high CV risk. For such individuals with hypertension with 1 additional risk factor, this 1 capsule could be of great effect in, especially in compliance and also managing their cardiovascular burdens. The advantages of this polycap are obvious. It improves compliance for both physician and patient. It reduces the cost because each individual component costs a lot. When put together, the cost is low. And the potentially large reductions in vascular events are possible if it is applied to a larger part of the society. There are obvious drawbacks that it could be a simple hypertension for one person, it could be an overkill for him for the risk factors. Atenolol is being questioned, hydrochlorothiazide is being questioned. There are disadvantages of fixed dose combinations, like somebody starts coughing because of ramipril, the whole molecule that has to be revised and we have to break down to original drugs. Yes, all these are known, but yet the positive effects are quite a few, and that's why we still have to think of polypill. My own loud thinking is that individual drug components work. There is no doubt about the usefulness of aspirin, the ACE inhibitor, or the statin. Then we know that hypertension, lipids, heart rate are all risk factors which we discussed. Cross risk factors commonly coexist. And secondary prevention, we end up giving all these 4 to 5 drugs in majority of the patients separately. Can one pill can be packed in 5 drugs? That was achieved by this innovation. All these 5 drugs remain pharmacologically stable? The answer was yes. Was the combination cheaper than individual drugs? The answer was yes. And can moderate doses have a desirable effect? For primary prevention, this is good enough. For secondary prevention, that is tips 2, probably double dose of this pill would do the trick by adjusting the doses correctly. This was my own prescription for an angioplasty patient getting discharged. She was on aspirin, clopidogrel, diuretic with ACE inhibitor, atorvastatin, metoprolol, and nitrates. So after some time, I thought this whole, though it's a neatly typed prescription, doctors are famous for their own handwritings, and we see how actually the prescription can look like this. There are so many drugs written and you don't know what cross connection would take place. So finally, after few months of this treatment, my prescription came down to this 1 polycap with additional clopidogrel, which was not there. It did not require nitrate anymore. So it was a crisper prescription, less number of drugs, obviously. From 5 to 1 is a major reduction in pill burden rather than just from 2 to 1 or 3 to 1. I was talking of this slide, I showed it earlier, that there is adherence as a major risk factor in addition. This was a study done in Bangalore which said that what is the biggest reason why non-adherence take place is unaffordability is one of the causes in India. And there are other factors like access barrier or recall barrier. I think it's very important. Old people, if you have a prescription with 7, 8 drugs, I don't know how they would remember, how they will take the pills. And that's why these factors of writing a prescription which is patient-friendly probably makes a huge difference. Rather than the quality of the prescription, the friendliness probably brings in better compliance and better effect for the patient. If you see the enhanced patient compliance here, if you have number of pills, 1 drug, 2 drug, 3 drug, 4 drug regime, the compliance starts dropping down. Once daily, twice daily, thrice daily, 4 times a day, the compliance starts dropping down. So all these factors considered, even such a simple trial, the same drugs actually had valsartan and hydrochlorothiazide, given separately had this much compliance and given together had a very large compliance. So again we are talking of compliance and adherence are exceptionally important issues. And this was one trial with Empire clinical trial. Nearly 2,000 patients. It was to assess whether a fixed dose combination delivery of aspirin plus statin antihypertensive drugs versus usual care improves the long-term adherence in medication. And the answer was yes. The polypill had a great adherence as compared to the usual care when the same drugs were given separately for these 2,000 patients. So recommendation from the elite organization on improving adherence is there, and fixed dose combination therapy reduces the dosage demands is what is the final bottom line. Typically a villager farmer comes to you, obese, he's hypertensive, only is a risk factor, but they all chew tobacco, so obviously there's tobacco chewing, he's an obese gentleman. So somebody like him, if you write 5 drugs which contains antihypertensive and aspirin and statin and other things, he's not going to take it. So for such individuals, probably it's a remarkable pill. For non-compliant, uneducated patients who do not follow very well, it's a great pill. For future direction with the polypill, somebody with a higher doses could be considered. Clinical outcome trials like HOPE-3, a large trial could be possible to do an outcome trial. And the polypill will force us to rethink our approach to prevention globally, and that's why I call it a social pill. So it offered to many people, individuals with 1 or 2 risk factors, probably subserve the country much better in reducing the overall cardiovascular burden. For we know that for masses, public transport is better than individual cars. And that is what the concept of polypill is really. Lancet in 2009 had these editorial comments about the polypill, that it's one step towards realizing the dream of global health, that is realizing the dream of reducing the overall cardiovascular burden. And of course we'll go to the last line straight away. The major appeal is simplicity, the low cost and improved compliance of the individuals. So we can sell it to the whole world actually and get Mr. Obama also look like this. So it is a concept, it's an Indian concept and it can go abroad as well. So I think this is a concept, an innovative idea to decrease the CVD risk with the improved compliance, adherence on one side and risk reduction on the other side. All are put into a good knot by this polycap. So I was trying to look for a photograph which will finally befit this. Risk factor burden is huge. We have to think of some policy by which we can control this. There is lifestyle modification, there is other aspects, but as far as the drugs concerned, probably this is what it is. Many drugs put, small doses put together probably drive away the risk factor burdens. Thank you.